The first disease process we'll review is Alzheimer's disease. This is a chronic, progressive, degenerative brain disorder that accounts for about 50% of all cases of dementia. It results in a very profound memory, cognition, and self care deficits. 10% of the population over the age of 65 will be affected. So 1 in every 10 adults over age 65 is affected. And it has been said that it's the most feared disorder of modern times. You see President Reagan here, and he was sort of the picture of Alzheimer's disease for a good portion of our lifetime. But I believe it was Nancy Reagan who said that having Alzheimer's disease was like an endless funeral. The average duration of illness before death is 8 to 10 years. So many patients and families must deal with this for a very long time. The National Institute of Aging estimates that $100 billion is spent annually in the treatment of Alzheimer's disease. And we know that there is a great deal of research being done in this area. This is just a picture that I found as I was reading about Alzheimer's, and I think that this must be how families and maybe patients feel, how they are just descending into sort of a darkness or a void. So I thought that was a very descriptive picture. Some of the risk factors for Alzheimer's, of course, are advancing age. We know that females are affected more commonly with Alzheimer's, and that there's a positive family history correlation. Children of Alzheimer's patients have a 50% risk of developing Alzheimer's. There is a genetic predisposition that can be determined by the presence of a protein, apolipoprotein E, which increases the likelihood of Alzheimer's. We also know that chemical imbalances and environmental agents and some immunological agents can cause Alzheimer's. Ethnicity is a factor. African Americans have a greater risk of Alzheimer's, and also we know that the Hispanic population develops Alzheimer's earlier than other races. Your book said there's also a high incidence in people with Down syndrome, which I had not heard before. We know that repeated head injuries and repeated head trauma, such as with some of our football, our athletes, our boxers, also plays a role in developing Alzheimer's disease. Alzheimer's disease usually begins very insidiously, very slowly, and it's characterized by a gradual loss of cognitive function. This is the pathophysiology. We know that these patients have neurofibrillary tangles and senile or neuritic plaques. This is the hallmark sign that we sometimes see reported out on MRI scans or CT scans. These tangles are masses of non-functioning neurons. We also know that an enzyme that is active in producing acetylcholine is decreased in the Alzheimer's patient. So this is somewhat of a disease of the neurotransmitters. The cells that are most affected in Alzheimer's disease are those that use acetylcholine. And we know that there's also an increased amount of abnormal protein called beta amyloid in these patients' brain tissue. So many of the medications that we use will be focused on decreasing the amount of beta amyloid and providing more acetylcholine to the brain to lessen symptoms. The symptoms of Alzheimer's are varied. There's a lot of them. We know that cognitive impairments such as attention and concentration and judgment and perception are altered. They may have learning difficulties. They have short-term memory loss, which is one of the first symptoms that is noticed, especially by families. They don't process information as fast, so their language and communication skills may be slowed. They're going to have changes in their behavior and personality, and I have 2 asterisks by this because this is the most difficult for families. They may become aggressive. They may be verbally or physically abusive. They have very wide mood swings, especially in the later stages. They have sundowning, which is a increased confusion, especially at night. They may become suspicious and paranoid. So these are some of the symptoms in behavior and personality. And I don't have one here that I want to add, and that is called wandering. We hear about patients with Alzheimer's leaving their homes or leaving their facility and being sort of caught outdoors. So wandering is a big issue that we'll need to focus on in our nursing care. They do have changes in self-management. Their personal care may not be as it was before. They may wear inappropriate clothing for the season or for the temperature. They may have loss of bowel and bladder control in the later stages. And also in the later stages, the decrease in appetite or the inability to eat just because they forget and they become less mobile. So these are some of the symptoms we'll see in our Alzheimer's patients and how we'll focus our nursing care. There's also been a lot of focus on how to treat these patients with drugs. And so some of these drugs have been developed just in the last couple of decades. The cholinesterase inhibitor drugs were the first ones that you'll recognize. They work by increasing acetylcholine levels in the brain's cortex and slowing degradation of the neurons. And you'll know them as Aricept, which was the first one, and then some of these others. Now, some of the side effects to these drugs are weight loss due to some of the GI upset that these patients have from these medications. So when we start these medications, these cholinesterase inhibitor drugs, we need to be careful and watch our patients' weight and make sure that they don't start losing weight. These drugs, the cholinesterase inhibitors, are also somewhat toxic to the liver. So we have to watch our lab work that tells us about our liver health. Memantine or Namenda is a newer class of drugs. It blocks the glutamate, which is what is actually causing one of the problems. The good thing about Namenda is that it can be given along with Aricept or one of the cholinesterase inhibitor drugs. I learned Namenda when it first came out that it was only given during sort of the middle stages of Alzheimer's, and that the cholinesterase inhibitors had to be given earlier in the disease. But that way of thinking has sort of gone out the window, and many times they will start patients on both of these drugs. Psychotropics would be used just to control some of the behaviors. I'm talking about Haldol here or Risperidol. Um, we have to be careful using psychotropics though, because the Joint Commission that accredits hospitals and extended care facilities see these as chemical restraints, and so we need to use the psychotropic drugs only as a last resort to keep the patient safe. And then some of the antidepressants you might see used are Paxil and Zoloft, the SSRIs. There is a new combination drug that I don't have on your chart. I see that they are advertising that on television. It's called Namzeric, Namzeric, and it is a combination drug of Aricept and Namenda. So many times getting these patients to take their medications is hard. They're a little bit paranoid. They may not be eating and drinking and swallowing normally. And so if we can get by with giving one pill rather than two, in this case it would be preferred. You also see the Exelon patches, which are cholinesterase inhibitors, and this company has put their cholinesterase inhibitor into a patch, and the patient then gets the medication transdermally. And it does help with that situation where it's hard to get the Alzheimer's patient to take their drugs. Okay, nursing care for the patient with Alzheimer's disease is very individual. We need to provide them a structured and consistent environment. They need to have a daily routine. Of course, safety is going to be the priority for them. We want to do everything we can in the fall prevention category, and we want to prevent them from wandering and becoming harmed. Cognitive stimulation, the example your book gave of this was animal assisted therapy, and I do see this being used in the extended care facilities where they have animal therapy. Memory training, where the caregiver would reinforce what memory the patient does still have functioning. An example of this would be providing a short video of family members for the patient. Reminiscence training refers to having personal items around the patient and then referring to them and helping the patient talk about what those personal items mean to them. It's important that they have undisturbed sleep at night. When Alzheimer's patients become very fatigued, they have increased confusion and increased agitation and aggressiveness. So sleep also needs to be one of our priorities. Reality orientation, at least in the early stages, where we remind patients what day it is, what time it is, where they are, who they are, having familiar pictures in their rooms, having clocks, having calendars. So reorienting them to reality, but more in the early stages. Validation therapy is just simply recognizing and acknowledging how the patient is feeling and what his concerns are, and saying that out loud. Promoting communication, very important. Lots of examples here, but we need to speak directly to the patient. We can use gestures if that helps the patient understand better. We need to use clear, short sentences with a calm voice. And it goes without saying that we don't want to shout or use a loud voice. We want to instruct them in doing one task at a time. And your book says that also having pictures of the instructions can help them understand what we want them to do. We may have to explain it. We may have to demonstrate what we want for them to do, but that is all examples of promoting communication. We want to ask simple questions, and this is a time where we do ask yes and no questions. You've been taught in psych to always ask open-ended questions to obtain more information, but with these patients, it's just simpler to ask yes and no questions. And also, lastly, we want to limit their choices because this decreases frustration and confusion. So my example of this was if you want to ask them what they want to wear, what shoes or what blouse, you would only give them 2 choices rather than 3 or 4, and this would decrease their stress and frustration. Reducing caregiver stress is very important. We know that these patients can live a long time and that they are progressively worsening with their symptoms. Your book also talks about counseling the family to obtain guardianship of their loved one, to think about the time for a durable medical power of attorney in case the patient becomes severe and unable to make their own decisions, and perhaps consulting a lawyer about their status. And I know that there is a growing elder care legal area out there. So these are just some things to think about as you're taking care of your Alzheimer's patient. And again, this is another nice little visual that I found as I was reading about Alzheimer's, and I like this a lot. It's for the lay people, of course, not for health caregivers, but I thought it was very pertinent, and I'll just let you read those for a moment before I move on. I thought number 5 was very good. It's almost a habit to say, yes, Mama, don't you remember this, this, this? Instead, we want to reminisce with them and have them sort of add to what they remember about something. So I thought these were good. All right, we're going to move on now to Parkinson's disease. Okay, Parkinson's disease is a slowly progressing neurological movement disorder. And the underlying cause is a decreased level of dopamine in relation to the amounts of acetylcholine in the brain. So again, a neurotransmitter problem. Nerve cells in the basal ganglia are destroyed, and this causes a decreased level of dopamine. The cause of Parkinson's disease is still listed as unknown, but we do know that environmental factors, again, exposures to chemicals, exposure to toxins, genetic factors, head trauma, and there's some thought that the decreasing amount of estrogen in an aging person may contribute to Parkinson's. Parkinson's has a gradual onset and a slow progression of symptoms in stages. We do know that it progresses faster the later in life the diagnosis is made. But it has a very chronic and prolonged course. It begins with a unilateral tremor of one limb. You see my picture of Michael J. Fox. You know, he had an early onset of Parkinson's disease and has been very verbal about his journey. Other celebrities that I noted had Parkinson's disease was Muhammad Ali, the boxer, Linda Ronstadt, and Neil Diamond were just some of the people that I read about. As I said, it has a very chronic and prolonged course, and eventually the cause of death will be some kind of infection, such as aspiration pneumonia or a urinary tract infection. There are 4 cardinal symptoms of Parkinson's disease. The first is a tremor. Remember, this is often the first symptom. A slow, unilateral, resting tremor. This tremor usually worsens when the patient starts to walk or starts to concentrate on something or is anxious. And we sometimes can see a pill rolling tremor. And if you will just think about having a pill between your thumb and your first finger, and you roll that, and then as they're rolling that pill between their thumb and index finger, they're also supinating and pronating their arm, and I will demonstrate this in class. The second cardinal symptom is muscle rigidity. They are very stiff and rigid. They have a resistance to passive limb movement. They cogwheel, which is sort of a rhythmic but then an interrupted gait. And again, they're very stiff. Bradykinesia is slow movement. It takes longer for them to complete activities. They have difficulty initiating movement, and they will tell you that they get frozen. They get stuck to the floor where they can't move. And one of the things that we can help them do if they get stuck to the floor and can't get started with their gait is to teach them to march in place, and then they will be able to propel forward. Postural instability because of the change in their posture. They have a very bent over posture. Their head is bent forward, and then they have this very shuffling, propulsive type gait, and their arms are very stiff. They don't swing their arms. They have a reduced arm swing. Okay, and I want you to look at all of these symptoms. I want you to memorize the 4 cardinal symptoms, but I want you to think about what a high risk for falls that this makes the Parkinson's patients. So safety and fall prevention is very important for them and is often the priority of their care. This picture shows the posture of Parkinson's. Again, their head may be a little bit tremoring and rigid. Their trunk is sort of tilted forward. Their arms do not move a lot when they walk. And then they have this shuffling gait with very short steps. Other symptoms we might see in the Parkinson's patients are depression or moodiness. They may have dementia on top of all these other symptoms. They don't sleep well, so they have sleep problems. Micrographia is just very small handwriting. and dysphonia, which is a hoarseness or difficulty speaking. They also may have difficulty swallowing, they may have some drooling, and they have difficulty chewing. And that puts them at risk for an aspiration, which we know is one of the possible causes of death. Okay, I'm sorry. Now this is about a 1 minute YouTube that shows the gait of Parkinson's disease, and I won't show it here. It doesn't broadcast well, but I want you to observe for the arms. I want you to see that they don't swing their arms like a normal gait. They have a very stooped posture. It takes him a few minutes to get started walking, and then when he turns around, he turns like a statue, and that's called en bloc, ENBLOC. So as you watch this video, I think you will recognize this gait. I think you've probably seen it a lot in your lifetime with family members or just at the mall, people walking, but you will recognize it now as the Parkinson's sort of shuffling type gait. Now, the goal of drug therapy and medical management is to improve their mobility and have minimal side effects. We want to control their symptoms and maintain their functional independence as long as possible. We're going to start pharmacologically, and there are lots of Parkinson's drugs. It can take several weeks for some of these drugs to sort of kick in and begin to work. The first ones we have are the dopamine receptor antagonist or agonist. You will recognize Mirapex, Requip in this category. They mimic dopamine by stimulating the dopamine receptors in the brain. These dopamine agonists work best in the first 3 to 5 years after diagnosis. The big side effect of this group of drugs is hypotension. Again, we have to keep our patients safe and prevent falls. The second group of drugs are the combination levodopa-carbidopa. You will know that as Sinemet. Sinemet is one of the older drugs. It's least expensive of the drugs. We need to know that it does turn your urine and your tears a darker color. And it's a very common anti-Parkinson's drug. Sinemet is to be given AC before meals. And I have a note that almost all Parkinson's patients have at one time used Sinemet, so it is very common, and you will see that a lot on your MARS. The COMT inhibitors are used with early or mild symptoms. They delay depression, slows dopamine removal, and the one you might recognize is Azilect, A-Z-I-L-E-C-T. Cimetril or amantadine is an antiviral drug, but it has anti-Parkinson's benefits, and so it reduces their symptoms. The anticholinergic drugs like Cogentin helps to decrease the very severe motor symptoms like the tremor and rigidity in Parkinson's, So that is more symptomatic control. Okay. From a nursing care standpoint, we do want to improve our patients' mobility as much as we can. We want to encourage them to take longer strides, use a heel-to-toe gait. We want to prevent injury. Again, I've talked about falls. We want to let them do as much of their care as possible. We want to prevent constipation. Many of the medications will cause a dry mouth and slowing of the gut, so we need to provide them with fluids. Nutritionally, we want to allow them extra time to eat. We want to give their medications on time because these do help them be able to swallow and eat. Remember, the Sinemet needs to be given AC or before meals. We want to provide them with good nutritious food, maybe supplements if possible. We want to do weekly weights on them and make sure that they are not losing weight. They may need a speech and language pathology report, consult to help with swallowing issues. And they may even progress to needing assistive devices such as a PEG tube or an NG tube for feeding. We want to communicate with them and improve their communication as much as possible. We need to take time for them to get their words out. Remember, their speech sort of becomes slower. We want to support their coping mechanisms, assess them for symptoms of depression and dementia, and we want to provide them and their family with community resources. And I know in Dalton, I see it in the paper every day that there is a Parkinson's support group that meets and provides support for patients and families. Just a word about drug toxicity. We've talked about several categories, and I've named you some of the drugs that are taken to help the Parkinson's patient. But please know that long-term drug therapy often causes some delirium, some cognitive impairment, and over time the drugs become less effective. If this happens, the medication dose would need to be reduced or maybe even changed entirely. We call this a drug holiday, especially when we're using levodopa therapy. This drug holiday can be even as much as like 10 days. And I will tell you that patients who have to go on a drug holiday because of either a decreasing effect of their medicine or other side effects do not like their drug holidays because their tremors increase, their mobility decreases, and all of those things. So just be aware that sometimes these drugs do have to be stopped and a new one started for a period of time. There are some newer invasive techniques that we're using with Parkinson's patients. The first one is a stereotactic procedure where they go in and do either a paleodotomy or a thalamotomy. A paleodotomy is surgical destruction of the part of the basal ganglia that is responsible for the dopamine acetylcholine inequality. These do help with symptoms. They do help control their tremors. A thalamotomy would be destruction of part of the thalamus, which is also used to treat the abnormal movements of Parkinson's. Now you see a picture of this deep brain stimulator, which is placed in the thalamus. It improves their motor function and helps to decrease some of the abnormal movements of Parkinson's. And then fetal tissue transplantation. And this works by providing more dopamine in the cells and providing more cells that produce dopamine. So many students have heard me say with Parkinson's, it's all about the dopamine. And so these patients, remember, have a decreased level of dopamine for various reasons, either a basal ganglia problem or they have an overproduction of acetylcholine that then sort of overpowers the dopamine. So all of the drugs and techniques that we're using is all in an effort to get more dopamine into the patient's system, because dopamine is responsible for most of our movement and that kind of thing. All right, so our next topic is going to be headaches. I'm going to talk about headaches in general, and then I will move more specifically into migraine headaches. But headaches in general is the most common of all human physical complaints. Headache is a symptom rather than a disease. We know that headaches can be very costly in terms of missed work days and medical treatment. So people who are plagued with headaches have a very difficult road to go. Primary headaches means that there is no cause, organic cause, that can be found for the headache. A secondary headache is due to something that can be identified, like a brain tumor or an aneurysm. With a headache assessment, we want to have the patient describe their headache. They should use a pain scale. They should describe where the headache is, whether it's one-sided or bilateral, and whether they have other symptoms that are associated with the headache, such as nausea and vomiting or photophobia. We want to ask them about their medication history, because we know that some medications can cause headaches, and we want to see if they're treating their headaches with any of the over-the-counter medications. We want to ask them about emotional factors such as stress. Have they been under more stress than usual? Do they feel depressed? Because we know that stress contributes to headaches. Do they have other people in their family who have headaches? Because there is a familial tendency to headaches. And then if they have been exposed to any other toxic substances in their environment, in their work, at their home, that might be causing their headaches. Some other questions we can ask them is, have you ever been hospitalized for headaches? Have you ever seen a specialist for headaches? And do you miss work because of your headaches? Again, knowing that a lot of work is missed with bad headaches. Sometimes patients are asked to keep a headache diary. It includes things like the time the headache began and the time it ended, how severe was the headache on a scale of 1 to 10. Can they identify any triggers that cause their headache? Triggers like the first day of a menstrual cycle for females, any medications they've taken, any thing they've eaten that caused the headache, like caffeine or chocolate or hot dogs. What kind of activities were they doing when the headache occurred? And were there stressful events that occurred with the headache? And so patients are commonly asked to keep a headache diary. I've got just a simple example here where you can see date and time started, how severe, triggers, and then what they did to relieve their headache. Some of the diagnostic tests that we might see ordered for patients with headache, of course, includes labs. A CT of the sinus, and this is what I'm showing you in this picture. You can see in the left lower picture, this is an x-ray where we're comparing black, which is air, open sinuses, to white, where something is blocking the x-ray. So you can see that in the left bottom picture, there's a lot more black than there is white, which means these sinuses are open and potentially not causing a headache. In the right lower picture, you see that there's not a lot of black, so there's not a lot of air passage as they should have, but a lot of white, which can be mucus, it can be tissue. So this is why we would do a CT of the sinus as an evaluation for headache. They may have a CT of their head to determine if there's any lesions or infections. They might have an EMG, an MRI, MRA, and perhaps an angiogram if they suspect any kind of abnormalities in the vasculature. Okay, now I'm going to focus on migraine headaches. This is a symptom complex that is characterized by periodic and recurrent attacks of very severe headaches. They occur more commonly in women with women who have a strong familial tendency, such as mothers, grandmothers, aunts, uncles. The typical onset of migraines is during puberty, which lends the thought that estrogen is one of the causes of migraines. Migraines have their highest incidence in patients 35 to 45 years old. Migraines have been seen as a vascular disorder. Iggy says that the cause is unclear, but that possibly it's a combination of vascular, genetic, hormonal, and environmental factors. We know that the headache occurs when the vessels to the head change from vasoconstriction to vasodilation. We also know that there's an abnormal metabolism of serotonin, which causes this vessel change. And we know that many triggers can start this process. Some of the triggers, as I've said, are the menstrual cycle, bright lights, stress, depression, sleep deprivation, fatigue, certain foods such as tyramine, monosodium gluconate, nitrites that are present in smoked meats like hot dogs and bacon, milk products including ice cream, aged cheeses, chocolate, and red wine are some of the common offenders. Other causes may be alcohol and tobacco. So this trigger causes a spasm in the blood vessel, which leads to vasoconstriction. The vasoconstriction causes some hypoxia to the cerebral vessels, and this increases serotonin release. Serotonin release also can cause prostaglandins to be released and cause inflammation. So many of the things that we're going to be doing is going to be decreasing serotonin levels and helping the blood vessels going to the brain and head to stay in either a vasodilatory state or a vasoconstriction state, because it's the change from one state to another that causes the headache. There are three categories of migraines, and there's a very good chart in your book. You have migraine without aura, and this is the most common type of migraine. It's also called the common migraine. There is a migraine with aura. This is called a classic migraine. An aura is some kind of sensation, or it may be a visual change, or a sound, or something the patient sees, hears, smells that signals the onset of a headache. And that is very important because many people can take a medication when they first have the aura, and they can prevent a very severe headache. Atypical migraines are less common, and I won't go into a lot of detail about those. There are three stages that a person goes through when they have a migraine. During the prodromal stage, the patient has their aura. They may have some food cravings. They may have mood changes. They may have some visual disturbances. My dad actually has migraines, and he sees what he calls a lightning bolt. And he knows that when he sees the lightning bolt, that he needs to take some medication, and perhaps he can prevent his headache. They also may have some other symptoms like tingling or numbness of the lips. You can actually have some unilateral weakness, either in your face or in your extremities, with a headache, with a migraine. They may become confused. They may have vertigo, and they may even have trouble getting their words out, or aphasia. So many of these symptoms will scare you to death. They look like stroke symptoms, but they can be occurring in the prodrome stage of a very serious migraine. Because if you think about what's happening in the brain, the vessels are either vasodilating or more likely vasoconstricting and leading to these symptoms. In the second stage, the headache comes on and is very severe. Patients describe it as throbbing. It's more often than not unilateral or one-sided, and the patient commonly has nausea and vomiting in this second stage. During the third stage, the headache sort of changes from this severe throbbing to more of a dull ache. They still may have some nausea and vomiting, but they're sort of on the downside by then. And then in this post-drome period, my dad calls it his hangover, but that's what it's sort of similar to. They are very fatigued. They may be irritable, and they may have muscle pains and be achy and just sort of feel bad during this post-drome period. So these are sort of the stages of migraines, and they can occur either with the common migraine or with the classic migraine. The three approaches to migraines are to first teach the patient to recognize their symptoms, and then they need to respond and see a healthcare provider, and then we need to find some kind of relief for their pain and symptoms. Management of migraines is about pain relief, so this is the priority of care with migraines. So we want to recognize, respond, and relieve. Pharmacologically, I will tell you that there are a lot of medications for migraines. I want you to divide your pharmacology here into abortive therapy, which is aimed at alleviating the pain after the migraine begins during the aura phase. Preventive is used on a daily basis if the patient has more than 2 headaches a week. So you would take it every day whether you had a headache or not. Let's go through the abortive. First line of therapy, acetaminophen or Tylenol. Sometimes this will help if the patient can take it during their aura before the headache begins. NSAIDs such as ibuprofen or naproxen can also be effective. Caffeine, which is a vasoconstrictor, and if you look at the migraine over-the-counter medications, they almost always include caffeine. I've heard patients say that as soon as they have their aura, they can go and drink a Coca-Cola or some kind of strong caffeine drink, and it will relieve their migraine. And then you have what we call the mainstay of migraine management, and this are the triptans. Now, you'll notice in the generic name of these drugs, they all end in triptan, which is why we call them the triptans. They are serotonin receptor agonists. They are going to cause a vasoconstriction in the blood vessels and decrease inflammation. Many of these are available as nasal sprays or inhalers or suppositories or even IM injections. Not surprisingly, 80% of people prefer the oral route. The side effect for the triptans is chest pain. Now, I told you that, the triptans act by keeping the vessels in the cerebral area in vasoconstriction and decreasing inflammation. But the triptans can also cause vasoconstriction of the coronary arteries. So if a patient has a history of angina or chest pain or heart attack, they will not be given or prescribed a triptan. That is an absolute contraindication. Ergotamines are older drugs. They act on the smooth muscle of the cranial blood vessels to constrict them. They are low cost and very effective. Midrin is also an older drug. It also constricts the cranial and cerebral arterioles, and I believe can be bought over the counter now. The newest kind of migraine drugs are called the ditans, and you have the generic name here. These ditans block only one specific serotonin receptor without causing vasoconstriction of the blood vessels. So it's very new, I imagine very expensive, but they say very effective. The CGRP antagonist is a new oral drug for acute therapy. You see it listed here, and your book did not give a whole lot of information about it. So just for completeness sake, I included these. But I would say that right now, the triptans are still being used quite often. Now, the preventive drugs are used again every day to prevent headaches. A patient qualifies, if you want to say that, for a preventive drug if they have more than 2 headaches twice a week, or more than 2 headaches a week. So again, the diary comes into play. Beta blockers, such as propranolol, timolol, atenolol, metoprolol, the LOL drugs, will keep the blood vessels in one state, sort of a vasodilation, I guess, and prevent them from changing to vasoconstriction and prevent the headache. The calcium channel blockers, like verapamil, decrease excitability of the neurons and can be very effective for migraines. Some of the anti-epileptic drugs or the seizure drugs are approved for migraine prevention. Topamax and Depakote are two of those. So I would say, looking at this slide, it's very busy, I know, but know the difference in abortive and preventive medicines. Know how to teach your patient when to take both of them, and know about the triptans, especially what the contraindication and biggest side effects of the triptans, which is chest pain, and a history of chest pain will keep you from being prescribed a triptan. Other management for migraines are listed here. Botox actually is approved for migraines. There are 7 specific sites in the head and neck which are injected monthly for 5 months. Other alternate therapies are listed here, and we've seen all of those before. Some of them can be very effective. B2 or riboflavin has been shown to help with headaches or migraines, and you would need 400 milligrams once a day. Coenzyme 10 also can help with migraines, and the dose is 300 milligrams once a day. A new addition to your book was the use of medical marijuana for headaches. There have been small studies that showed that medical marijuana was very effective, but your book says that needs more study. Comfort measures. Patients want to be in a quiet, dark environment. They do better if the head of their bed is elevated. We want to provide them with antiemetics for their nausea and vomiting. We want to teach them what foods and beverages to avoid. Tyramine containing foods, we've named those again. Some of these pickled products, avoiding caffeine, avoiding beer and wine. Very preserved foods all have a lot of tyramine. Meds to avoid are things like estrogen, nitroglycerin, and Tagamet or cimetidine. Other causative factors might be teaching patients to avoid skipping meals, to get enough sleep, to avoid smoking, and try to avoid stressful situations where they become very angry or distressed. Okay, the next topic in this chapter are seizures. These are defined as episodes of abnormal motor, sensory, autonomic, or psychic activity that results from a sudden excessive discharge from the cerebral neurons. Epilepsy is simply defined as a person who has had 2 or more seizures. This is how we classify seizures. We classify them as generalized, which involves the whole brain, or partial, which involves only one part of the brain. Under generalized seizures, you see tonic-clonic, and this is what we used to call grand mal. These are tonic-clonic seizures where you have a stiffening and rigidity of the muscles, a loss of consciousness, and then a rhythmic jerking of the extremities. A tonic seizure is where the patient only experiences the stiffening and rigidity and loss of consciousness. So they don't have the jerking, they just have the rigidity. Clonic seizures are where the patient only has the rhythmic jerking but no muscle contraction or increased tone in their muscles. Myoclonic is characterized by a severe but very brief jerking which lasts only a couple of seconds. Atonic is just a sudden loss of muscle tone with the patient falling to the floor. So we will focus on the tonic-clonic type of seizure in just a moment. Partial seizures are also called local seizures or focal seizures. These involve only one part of the brain. A simple partial seizure means that the patient remains conscious but has a funny smell or a funny taste or a vision or somewhat of an aura type sensation. A complex partial seizure may cause a loss of consciousness in the patient. And these patients also have what we call automatisms, where they may start licking their lips or clicking their teeth or doing something very repetitive of which they are unaware. Then you can have a partial seizure that evolves into a generalized seizure. So this would be a seizure that started in one side of the brain and then crossed the corpus callosum into the other portion of the brain. Status epilepticus is a sustained seizure that lasts more than 5 minutes, and we will also talk about how to treat those patients. There are many, many, many causes of seizures, and so this is just a partial list, but we know that infections like meningitis and encephalitis will cause this abnormal neuronal activity. Inborn errors of metabolism, and the example here is PKU in infants. Congenital malformations of the brain. Acquired metabolic disorders. This would be things like uremia, toxic metabolites of people that are in renal failure. A low sodium level will cause seizures. High or low calcium levels, low glucose levels. So we're talking about abnormal electrolytes. Structural lesions would be like tumors, stopping their medications abruptly, beginning new medications can cause seizures. Drug or alcohol withdrawal, such as with cocaine and others, but also with the antidepressants. If you stop them abruptly, you can have a seizure. Fever, especially in children, can cause seizures. Menstrual cycles or hormonal changes. Flashing lights like strobe lights. Emotional stress. Intense physical activity, which might lead to electrolyte imbalances, etc. Extreme fatigue, loud music and noises, and exposure to toxins and poisons. So lots of different causes for seizures. Some of the diagnostic tests you could expect for someone with seizures would first be a CT of the brain. They're obviously looking for structural reasons like a brain tumor or some kind of space occupying lesion that could be causing seizures. They might do an MRI. They might do labs where they're looking for those metabolic changes, skull x-rays. But an EEG, electroencephalogram, where they put the 16 electrodes on the patient and look at the brain waves, is going to be the test of choice. You can see the seizure activity on this EEG reading. We would never be asked to read these as a nurse, but I wanted to show you what the readings look like. It's very obvious where the patient was having a seizure. And then they might have a CT PET or a SPECT scan. Now, if all of these sort of don't reveal a reason for the seizures, you might see a lumbar puncture done here too. Okay, we want to be sure if we're in the room or with the patient that we can describe the seizure, because it will help the physician know sort of how to focus their diagnostic workup and their care. We want to look at what the circumstances around the onset was, what was the thing the patient was doing right before that. Did they have an aura? Did they say something or smell something or have an aura? How long the seizure lasted? What kind of motor activity did they have? What kind of movements did their limbs have? Was it bilateral or only one-sided? Did their eyes or tongue deviate to one side? What was their state of consciousness? Could they still speak to you? Were they distractible? Could they follow commands? Could you distract them away from the activity they were having? What did their pupils do? Were their teeth clenched? Were their respirations altered? Did they have abnormal body activities such as incontinence? Or did they have those automatisms where they smack their lips or click their teeth, or it's very individual but a very repetitive type of motion? Can the person or family describe any precipitating factors? And what did the patient do after the seizure? Were they confused after the seizure? Did they go to sleep? That kind of thing. Now I'm going to move on and talk about tonic-clonic seizures, or grand mal seizures as we used to call them. This is where the entire cerebral cortex on both sides is involved. The patient does lose postural control and fall to the ground. They have bilateral tonic extension of their extremities where they get very stiff, and then clonic activity where they have rhythmic movement of their extremities. They may have some very primal type sounds that escape from their throat. It's been described as sounding like an animal. The glottis is closed, and when the patient begins to have a seizure, the glottis closes, and these sounds sort of escape past that closed glottis. These patients do have a post-ictal state where after the seizure has ended, they are hard to arouse. They may be very, very drowsy and tired, and they're confused and don't have any memory of the event. Often they lose continence of urine and stool, and again have no memory of the seizure. With these patients, our care is very important. We have to keep these patients safe. Again, safety is a big priority. We want the bed of these patients to be in the very lowest position possible. Now, there is some controversy about whether we need to have the side rails up, whether they need to be padded. The thought is that padded side rails may embarrass a patient, and that having all of the side rails up might be construed as restraints. So you will use your hospital policy here for what to do with the side rails and padding. They need to have IV access. So patients who come in with a history of seizures or on seizure precautions need to have an IV access, at least a INT, before they have a seizure, because it's almost impossible to get an IV in these patients after they have begun that tonic-clonic activity. You do want suction and oxygen at the bedside just in case you need it. Your book is very clear about not trying to put anything in the patient's mouth after their jaws have sort of locked and they have begun the seizure. We can break teeth, we can get bitten, and they don't really do any good. Patients cannot swallow their tongue. That's physiologically impossible. And I know lay people, visitors, family, still talk about patients swallowing their tongue, but they cannot do that. Can they occlude their airway? Yes, if their tongue falls back. So we do need to turn them onto their side and loosen their clothing. We want to stay with the patient. If they're in an area where there are other patients, we want to be sure and provide their privacy. So we want to pull curtains. We want to keep other patients and families from seeing that. Patients wake up if they've had seizures before and they're very embarrassed, and they want to know what they did, and they want to know who saw them. So I can't stress enough the importance of privacy during a seizure. We do want to reorient that patient when he awakens from that post-ictal state, and we can tell them they've had a seizure, and we can tell them, whatever they want to know about that. And we want to report the seizure accurately. And that goes back to that list of things that I gave you about timing it, describing their activity, and those factors. If you were outside the hospital and you were a layperson, we want to teach patients and families to protect the patient's head and neck. We want them to roll them on their side. Make sure their airway, breathing, and circulation are intact, and call 911 for help. All right, that's what you do outside the hospital, and it's what we teach patients' families to do. Protect their head and neck, roll them on their side, practice the ABCs, and call for help or 911. Status epilepticus is defined as a continuous seizure that lasts more than 5 minutes or repeated seizures over the course of 30 minutes. It is considered a medical emergency because it is often accompanied by respiratory distress. And when the seizure lasts 5 minutes or the patient doesn't have time to recover between seizures, then you do get into an airway issue and a respiratory distress issue. You always want to have oxygen and suction equipment at the bedside. These patients are going to need IV access, and it may be that we need to try and get an IV in them after they have come into the hospital in this state, but it's going to be difficult. We are going to treat them with IV lorazepam. This is the drug of choice for status epilepticus. I'm going to say that again. IV lorazepam, 2 to 4 milligrams, is the treatment of choice for status epilepticus. If you cannot get an IV in them, there is a rectal Valium gel and suppository that we can use, which would be the second option. After the Ativan or the Valium is given, the patient will need to have a IV drip of either Dilantin, which is phenytoin, or more commonly Cerebex, which is fosphenytoin. Dilantin or phenytoin is not very stable at room temperature. It doesn't like to be mixed with dextrose at all. So Cerebex in a mini bag and infusing at a slow rate is to be expected after we give the IV Ativan or rectal Valium. These are the reasons that patients get into a status epilepticus situation. They suddenly stop taking their analeptic medicines. And we need to teach patients they can't just stop taking this medication, because this is what will result. If they have a lot of cerebral edema or swelling, like in the case of a head trauma or a brain injury, metabolic encephalopathy, again, alterations in the liver, in the kidneys, can cause toxic metabolites to build up in the brain and cause status epilepticus. Of course, acute head trauma because of the cerebral edema that comes after that. Infections that lead to septicemia, either secondary to or caused by encephalitis or meningitis. And then acute alcohol or drug withdrawal can cause status epilepticus. Pharmacological therapy for seizures is listed here, and there's a lot of them, okay? The goal of pharmacological therapy is to achieve seizure control and therapeutic blood levels with minimal side effects. You'll learn that many of these drugs do require patients to have blood levels checked, and so I'll come back to that. Phenytoin or fosphenytoin, we know as Dilantin or Cerebex, is one of the older drugs but still used. It has many side effects. One of the big side effects of phenytoin is gum hyperplasia. So we have to really inspect the patient's gums and encourage good dental care and oral hygiene. Phenytoin is also very highly protein bound once it's given. And so it will compete with other drugs for a site on the protein. The one drug we really worry about with Dilantin is warfarin or Coumadin. And so you cannot put a patient on warfarin and phenytoin at the same time. It decreases both their effectiveness because they're both competing for binding sites on the proteins. Some others listed here you'll recognize: Tegretol, phenobarbital, the Depakotes and Keens, Neurontin, Klonopin, Topamax, some of the ones that you may recognize. I have a lot of experience with Keppra. It has very few side effects, very few drug interactions, and is a good drug. But it may not, be good for everybody. I have a family member that takes Keppra. So these are just some of the ones that you'll recognize and know that we have to encourage them to take their medication as ordered, not to stop it abruptly, and that they must have drug levels done periodically, usually, once they're stable, about every 6 months to a year. We've covered a lot of this. We want to evaluate their current blood levels, beware of drug and drug food interactions. We want to teach them to maintain a therapeutic blood level. We can't give warfarin or Coumadin with phenytoin or Dilantin, and we want to really be sure that we report any side effects of any of the drugs. Now, many of the drugs do have a side effect of sedation or sleepiness. Remember, they are calming the brain down. Phenobarb, for example, is a barbiturate, so it is a downer in quotation marks. So we need to make sure patients know that that is a side effect. We need to teach them that they can't stop these abruptly. If they have income issues or expensive drugs, we need to hook them up with social services. I want you to know that this is a very high discriminatory area where patients with epilepsy or seizures can lose their jobs, and that is prohibited. And so we need to be an advocate for the patient here. You think about people who drive semi-trucks, people who fly airplanes, operate heavy equipment. Those people are going to be restricted from working for a while until their seizures are under control. So they may need some vocational rehabilitation. In Georgia, driving after a seizure is prohibited for 6 months. So patients may not be able to drive until their seizures are controlled. Some patients may go 5 months, think they're doing well, and only have another month to wait and have a seizure, and then their 6-month waiting period starts over. So I want you just to think about the implications of younger people who have seizures not being able to drive, or mothers who can't take their children to school because they can't drive. And the driving restriction is very hard for many. These are some of the surgical treatments that can be done if pharmacological treatment is not working. The vagus nerve stimulator is sort of like a pacemaker, where the leads are placed on the vagus nerve, and if the patient has an aura, he can then stimulate the stimulator to fire and abort the seizure. It sort of works on a neurotransmission type situation. Your book talks about this. The other 4 procedures here basically involve removing the portion of the brain where the seizures are originating from, and those would of course be used as a final resort to control someone's seizures. Just a word about seizures in children. They are most common during the first 2 years of life and are due usually to birth injuries or congenital defects in those early years. Once they get up past about age 3, they can be due to infections, high fevers, or in some cases idiopathic, where we don't really know what is causing their seizures. These are some of the common triggers in children, and I won't read through those as this video is getting very long, but I want to focus on this extreme changes in temperature. If a child's fever goes up slowly, they may not be as prone to febrile seizures as someone whose temp goes up very rapidly, and that sort of makes sense. And the last one, insufficient protein in the diet. This really refers to children who are taking anti-epileptics for seizures, need protein in their diet for those medications to bind to and to metabolize properly. So if the child doesn't have sufficient protein in their diet, there is nowhere for the medications to bind. Febrile seizures in children are transient disorders that occur with fever. They only affect about 3% of children, and most of these occur after 6 months of age and before age 3. These are usually the generalized seizures where they affect the entire brain and can be very scary. These seizures usually last less than 5 minutes and commonly accompany upper respiratory or GI infections. They are controlled with Valium in the child, and surprisingly, sponge baths and Tylenol will not usually help prevent these seizures. Okay, and the last topic in this chapter is meningitis, which is defined as an infection of the meninges of the brain and spinal cord. Meningitis can be caused by bacteria, by viruses, which is the most common type of meningitis, by fungi, and by protozoa. Viral meningitis is sometimes also called aseptic meningitis because there's no organism that grows out, say, on a CNS. But some of these common viral organisms are enterovirus, herpes simplex, varicella zoster, which is the chickenpox shingles virus, the mumps virus, and the HIV virus. Okay, with viral meningitis, usually the neurological deficits are not as severe and they're more likely to be temporary, and a full recovery can occur. So I guess if you have to have meningitis, you want it to be viral versus bacterial. Bacterial meningitis is the most serious type of meningitis, so I'm going to focus on it. And the most serious type of bacterial meningitis is meningococcal meningitis. This is considered a medical emergency. It has a very high mortality rate. It can cause some very serious lasting complications if they do survive, such as deafness, blindness, amputation, some very serious complications. It's very highly contagious, so a lot of focus is being done on prevention of meningococcal meningitis. Outbreaks of this occur in areas of high population density, such as college dorms, military barracks, and crowded living arrangements, such as prisons. So we have focused on 2 vaccines for prevention of meningococcal meningitis. There is one vaccine for ages 11 to 12, and they receive a booster at age 16. There is also a vaccine for adults, and most colleges require that young adults who are living in dorms must be vaccinated for meningococcal meningitis. Other things such as infections around the head and neck can also increase the risk of bacterial meningitis. Disease processes like otitis media, that's an ear infection, sinusitis, tooth abscess, and even tongue piercings because of the close proximity to the head and neck, and the meninges can be infected by bacteria from these disease processes. So again, a lot of focus on prevention of this kind of bacterial meningitis with vaccines. Regardless of the cause of the meningitis, whether it's bacterial or viral or fungal or protozoal, these are some of the symptoms that you can see. The patient will have a change in their level of consciousness. They may be drowsy, they may not be oriented. Any change is significant. A severe headache, photophobia, nuchal rigidity, stiff neck, nystagmus, that rapid eye movement, hemiparesis or hemiplegia, fever, chills, nausea and vomiting, tachycardia, and seizures. Now, the red macular rash that you're seeing a picture of here is pretty specific to the meningococcal meningitis. In fact, it's called a meningococcal rash. I like this picture because it just sums up all of the symptoms of a meningitis. This is the meningococcal rash. It again is usually only present in the bacteria. Meningococcal meningitis, it is a red macular rash on the trunk and extremities. So if you ever see a patient with this kind of rash, you need to be very alert. These are two ways that we assess for meningeal irritation. Koenig's sign is performed by having the supine patient with his hips and knees flexed extend his leg passively. The test is positive if the leg extension causes pain. Okay, when he extends his leg, it stretches the meninges in the back and he has pain. Brzezinski's sign is positive when passive forward flexion of the neck causes the patient to involuntarily raise his knees or flex his hips. Again, we're stretching the meninges in the neck, which is causing him to try and compensate and causes him to flex his hips. Now, your book does say that these two assessments are not very reliable, and sort of downplayed these two signs, but I feel you need to know them because NCLEX and they like to ask about signs and assessment mechanisms that are named after people. So please add these to your list of assessment techniques. The diagnosis for meningitis is usually done with a CT scan initially to identify potential sources of infection like an abscess. Blood cultures may be done to see if it has progressed to septicemia, where it's in the blood, and then a lumbar puncture to obtain CSF and try and identify the organism. And we've already talked about the samples will be sent for cell count, differential, protein levels, culture and sensitivity, and gram stain. This is how we would care for the patient. We would, again, prevent it with vaccines if possible. Focus would be on the ABCs and neurochecks and vital signs every 2 to 4 hours. They are going to need broad spectrum antibiotics. These patients will have a headache and perhaps neck pain, so they need pain relief. They need to be in a quiet environment, and they're photophobic, so they might want it dark. They need to be on bed rest with their head elevated 30 degrees. If it is bacterial meningitis, they need to be on droplet precautions, and that's important to remember. Seizure precautions, we know that meningitis is a cause of seizures, and if it is the bacterial meningitis, it may be necessary to treat contacts that were around this patient. The doctor would decide that, and he would prescribe medication for close contacts. The 3 medications we treat contacts with are rifampin, which is a TB medication, ciprofloxacin, and ceftriaxone. Okay, that is the end of this chapter. It's long, I know, but thank you for your attention.